So please welcome back Associate Professor Antonio Vigano and Ms. Virginia Basis. So today's program we will have a workshop. So most of today's program will be a workshop and we'll be looking at cases, right? Cases brought from Canada from both of our experts. So we can have a kind of hands-on approach on how to approach the medical cannabis in our patients today. So we'll start this morning by having two more talks from our experts, and then we'll divide into small groups. So you'll notice that the room right beside us here, we set up some tables for you. So we'll be dividing our participants into 10 groups, right? So, and in the small groups, we'll have cases for you to discuss, and we ask that you have one representative from each group to present your findings and results of the discussion to the large group. Okay? So, and this will be done later on. But first, let's start with the first session. Patients reading intake and setting up titration protocol by Ms. Virginia Basis.
Good morning, and thank you again for the warm welcome. So, I'm the nurse in the medical cannabis program at the McGill University Health Center, and I'm a pivot nurse in oncology, and I'm working sometimes in Santé Cannabis too. So I have no disclosure. So today an overview of the presentation. So legislation, indication, contraindication and precaution, and the evolution of health condition. And I separate my two presentations. I will go over the titration in another presentation right after. So about the legislation is like you have to know if the cannabis is legal for medical purposes where you are working. So the legislation in Thailand, so when I did the preparation, I think there was a change since then. It was in the Asian Cannabis Report. So I think you know better than me what the situation right now. So it's legal for medical purposes in Thailand, and you will have access to different type of oils who will be rich in THC and balanced oil with a ratio THC and CBD. In Canada, so cannabis is legal either for medical purposes and for recreational purposes too. So if the cannabis is required for a condition, the physician must provide the patient with a medical document to allow cannabis for medical purposes. And the patient in Canada can buy the cannabis through a licensed producer for medical purposes. And they can grow it as well, and they can have someone to grow the cannabis for them too. And there's two prescription of cannabis, derived product from cannabis that are available in the pharmacy. So yes, and it's legal since 2001 for medical purposes in response to a court ruling. So, and the Collège des médecins, so du Québec, it's the order of the medical in the province of Quebec. They have some rules for the doctors. So it can only be prescribed if medically necessary. It cannot be the first choice of treatment. So conventional treatment should have been tried first. The patient must be assessed by a physician and have a regular follow-up. And they must give free and informed consent, and they can choose their supplier. So the indication to the cannabis treatment. So at Santé Cannabis, they saw a lot of different type of disease. At the medical cannabis program at the MUHC, we only follow a cancer patient. So patient at Santé Cannabis, the indication will be that showing potential benefit with the medical cannabis, chronic pain, cancer and non-cancer pain, fibromyalgia, osteoarthritis and rheumatoid arthritis, HIV, multiple sclerosis, cancer, cachexia, anorexia, chemotherapy, induced nausea and vomiting, epilepsy, spinal cord disease or injuries, post-traumatic stress disorder, depression, anxiety, insomnia, gastrointestinal disorder. So they must show an evidence that they tried conventional treatment or medication. And they ask, because at Santé Cannabis they don't have access to all the dossier, medical file of the patient. So they ask the specialist to send to Santé Cannabis more information. At the medical cannabis program at the MUHC, we have access to all the patient file. So to have access to our medical cannabis program, the patient must have a diagnosis of cancer, must be treated at our hospital, and must have symptoms related to cancer or its treatment. And the same, we need to have evidence of trial of conventional medication and non-pharmacological treatment prior. So contraindication and precaution. So patient under 25 years old, it's better to avoid any product with THC for the brain development. Women who are pregnant or planning to be pregnant or breastfeeding, it's a contraindication to use cannabis. Unstable, uncontrolled heart disease, it's a contraindication to use THC. Severe hepatic or renal dysfunction, so we need to be very careful and to have the lowest dose and the minimum administration per day. History of addiction. Severe lung disease is more for inhaled or smoked cannabis. Personal history of psychosis or schizophrenia. The risk is more with THC. And for sure allergy or sensitivity to cannabinoid. So general precautions, if the patient is sensitive to THC, in the history we will adapt our treatment. If they are using, they need to, in their work, to drive or to operating machinery, to use THC during the day can be contraindicated. If they have a reduced mobility, vertigo or dizziness, history of substance abuse in the past for elderly patients, and we engage with our patient to reduce harms, so to the harm reduction, so to not use cannabis from illegal sources. I will just let the people sit. So cannabis can interact with some medication. So warfarin, duloxetine, cyclosporine, tacrolimus, clobazam, valproate. So, and it can interact, so the cannabis can have more effect if used with a sedative or alcohol or other drugs too. So significant interactions are rare. So, and for clobazam, usually if you use CBD oil, it's better to reduce or even stop the medication. So some interaction has been demonstrated with immunotherapy too. It decreased the response rate, but no change in the overall survival. So it's a balanced benefit risk. So sometimes we stop cannabis if the patient is on immunotherapy. And smoking cannabis carries similar risk as tobacco. So the recommendation in pre-operatory is to stop all smoked cannabis product. So evolution of the health condition. So it's important to continuously assess patient health condition in the clinical practice. Their medical condition can evolve over time, especially in supportive and palliative care. Medical cannabis prescribed and followed by a physician and a nurse is the best way to monitor possible interaction and the side effect. So in palliative care, some indication are pain, neurologic disorder, gastrointestinal conditions, sleep disturbance, and some psychiatric conditions, so more anxiety and depression. At this point, do you have any question or comment?
You said we must use precaution with some of the medication. What exactly the action of precaution? We reduce the dose, we skip the dose, we stop the drug.
So, first of all, precautions is different than contraindication. Okay, so it's not that it's a total not use. Okay, but with certain medication may accelerate the metabolism of the cannabis. And with other medication, cannabis may slow down the metabolism of the other medication. So depending, but I always to go back and reassess. When we are talking about clobazam, is almost I would say a contraindication to the use of CBD. Because for patients, when they are adjusted, the dose is a very, very narrow therapeutic window. Okay, so the minimum change in the metabolism will have some consequences. So with clobazam, even if we would like to use CBD because it's safer, we don't use it, and we need to use THC. And but again, it goes from medication to medication. For example, with warfarin, we are not completely sure if that would be clinically significant. Okay, depends also on the dose of warfarin. If the dose is very low, in general, it's not an issue. So it's a case-by-case situation, but it's obvious that it's important to know. And above all, it's a similar story with methadone. You know, people that use methadone for pain control know methadone is very tricky to use because it's very much influenced in its pharmacokinetic by concurrent medication. Similar things applies to cannabinoids, but in particular to CBD. THC is primarily related to renal failure because there might be a decrease in the excretion of THC by products. It's less intensive in terms of metabolism at the liver level. So it's really primarily cannabinoids. In terms of a pharmacokinetic, CBD will be primarily liver-related, THC kidney-related, both actually to kidneys because both are eliminated through the kidney. But again, the approach would be to be cautious and to start at the lower doses whenever we suspect that there might be a significant interaction.
Is the heart condition absolute contraindication for
Okay.
this?
So, with a heart condition, in general, the factor that will be at risk is the use of THC. So CBD will be absolutely safe. Now, having said that, even there, we may have to consult with a specialist and ask him, if THC would be really contraindicated. There are certain patients who had, myocardial infarction 30 years ago. They were otherwise fine since then. They are not on any sort of cardiac medication. We still like, also for our protection, to ask a cardiologist. So, but most of the situations that are stable. And there are also patients that unfortunately only benefit from THC and not from CBD. In those patients, we'll have to first document the case very appropriately, understanding that the patient wants to take some risk, and we have had limited, trial of products. Sometimes we try, a combination THC CBD instead of just going with THC, so that we have a bit of synergy anyhow. But then, it's a bit of, trial and error. But again, it's good to work with a specialist, with a cardiologist.
Regarding indications for use in spinal cord injury, is mainly used for controlled pathology or used for pain related to spinal cord injury? And my second inquiry is for stop using before surgery, for how long that the patient should stop? The first one is for indication in spinal cord injury. It's for the pathology or for pain related to spinal cord injury?
It's obvious that it will be for both, meaning you will have an anti-inflammatory effect from the CBD and also an analgesic effect from the THC. It's obvious that we are talking about neuropathic pain, which is more challenging to treat. At times, it's always good to give, a THC, a CBD-rich product trial first, but in your condition, you will go with a one-to-one. And I would say that probably just THC may not be best indication for this problem. Also in relation to the neuroprotective effect that the CBD has, that THC doesn't. So it works essentially both at peripheral level and a central level when you have the two, CBD and THC, balanced product. When you're using THC only, it's only central and may not be as effective also with a problem with inflammation.
And stop for how long?
Sorry, there was also the issue about perioperative. So, yes, maybe Virginie, you want to comment something? Okay.
So it's more like for the smoking cannabis that is the same as tobacco, that in pre-op we encourage patients to not smoke prior, because it will decrease the time of healing, and if they are like using oils, we will decrease it until they stop, because they cannot use it when they cannot eat, or so if they are using oil, we can decrease until we stop the oil to not have like withdrawal symptom. But otherwise, it's more like for the smoking problem in pre-op.
And then after surgery, they can start using at once? After surgery?
After surgery, yes, when they can start to go to eat again, yes. So after that, when they stop, they have to restart slowly from the beginning to titrate their oil. They cannot go back on the same doses that they were taking prior to the surgery.
Obviously that now with a new delivery system, we may see a difference, in the ability of the patient to continue with cannabinoids. Okay, so with the transderm patch, with the sublingual preparation, with sprays. I think the only aspect that is a bit tricky, and again, maybe the pharmacokinetics of this product during anesthesia. So we tend to reduce at minimum the use of cannabinoids, and when we restart, as Virginia was saying, it's like we have our receptors that are reset. Okay, so the tolerance that was developed before disappears. So you have to be careful. So you're starting as the patient was again naive.
May I ask about the timing? I mean, when the patient stop cannabis, maybe from operation or they forget or something. So it take how many days before we need to go back to the start of medication?
So we need to always to bear in mind the half-life, of the oils, and the fact that in order to reach a steady state, we still need 5 half-lives. So that what means is that, if still after 3 days when you stopped an oil, there might still be some cannabinoids circulating. Generally speaking, when we do cut down, we cut down every 3 days by half of the dose, okay? And so that no matter where the patient is in terms of dose, in about a week, 10 days, it can stop completely. At times, this is done also for patients who are traveling abroad, traveling outside. You cannot really carry any natural cannabis product. You can carry menabilon, which is a very good resource for us, okay? But you can't do that. But this type of holiday on cannabinoids is a good thing. It's like resetting your receptors. So, and generally speaking, our patients, they do stop cannabis because they go south, because it's like from Canada to warm places, and they have less issues with pain in general, so they can tolerate even being off treatment. But what they notice when they go back is really the effect again of cannabis. Sometimes patients say, well, I've been a year on this dose, it's really doing still something to me, I mean, do I need still to continue? And the only thing that at times we can suggest, obviously, if those are not cancer patients, because if you are cancer, we will have to reassess the stage of disease and things like that. But in chronic pain, never say never. I mean, we tell the patient, try to reduce it and see or stop it and see what happens. I mean, if they are okay, maybe things have changed, their sort of homeostasis is regained and they really don't need it anymore, there is no point to continue. But you need always to do it in a progressive way, never cold turkey. Even if you have just CBD. I mean, obviously THC is a bit more challenging because there's more central effects in terms of withdrawal potential, but even the CBD can if abruptly stopped, can give you trouble.
May I spend some time to make a summary in Thai?
Yes.
Because I think some nurses could not follow, or even some doctor, right? โอเคขอสรุปเป็นภาษาไทยนิดนึงนะคะก็มีอาจารย์ถามว่าอย่างคนไข้ที่จะต้องไปผ่าตัดอย่างเงี้ยก็ต้อง NPO เราจะหยุดยาเมื่อไหร่เขาก็บอกเมื่อไหร่ที่ NPO ก็หยุดยาเมื่อนั้นแล้วหลังจากที่หยุดยาเราจะเริ่มออยเมื่อไหร่นะเขาก็บอกว่าก็เมื่อไหร่ที่คนไข้เริ่มกินได้ก็เริ่มออยไปเลยแต่อันนึงที่ต้องระมัดระวังคือถ้าเขาหยุดยานานคือรีเซพเตอร์เขาจะรีเซ็ตใหม่เพราะฉะนั้นจะเริ่มในโดสขนาดที่กินตั้งแต่แรกๆตรงนั้นไม่ได้พี่ก็ถามว่าถ้าอย่างนั้นมันกี่วันล่ะพวกอย่างเงี้ยที่มันจะต้องเริ่มใหม่เขาก็บอกว่าอย่างสมมติว่าเขาจะทายลดคานนาบิสลงเนี่ยวิธีการลดของเขาจะลดลงกี่เปอร์เซ็นต์นะเดี๋ยว30% นะคะลดทีละครึ่งทุก3 วันนะทุก3 วันลดเพราะฉะนั้นโดยทั่วไปประมาณ10 วันเนี่ยสามารถที่จะหยุดยาได้นะเพราะฉะนั้นสมมติว่าถ้าคนไข้แบบขาดยาไปนานลืมกินยาไปเป็น10 วันอย่างเงี้ยเราอย่าไปเริ่มโดสเดิมที่เขาเคยใช้ต้องไปสตาร์ทจากโลโดสแล้วไต่ขึ้นมาใหม่นะ Okay, can I ask you, will they have a withdrawal symptom during the time that they don't have cannabis?
they do what kind of...
If they stop cannabis, will they have the withdrawal symptom
Yes.
if they have taken for a long time?
Yes. So I would say that again we are talking about central effect for withdrawal and peripheral. Primarily the peripheral will be the anticholinergic effect that is reversed very abruptly, and that will give patients become sweating, become very nervous, and at times obviously we have returns of the symptoms in a sort of rebound situation, like insomnia. They will not be able to close an eye through the night, if they were taking THC at night. And in certain ways, I think is similar to the opioid withdrawal. So this is always to keep in mind. Again, it depends from patient to patient. It doesn't necessarily mean that a small dose will not give a lot of side effects for withdrawal, because patient may just be very sensitive to just a small dose. So it's not necessarily related to the previous dose or the maximum dose that they took, although that is obviously something to consider.
I think the withdrawal symptom doesn't last long for the patient, so it's within 1 or 2 weeks maximum they will finish their withdrawal symptoms.
Good morning. As far as I heard from the Royal College of Anesthesiologists of Thailand, they have decided to suggest to start cannabis for 3 days before the operation, because they were thinking of the 5 half-lives, and it might be like 5 days, which is not too fairly for the surgeons, so they decided for 3 days. But they will stop 100% within 3 days, so they may encounter the problem of withdrawal symptom. Because if we don't stop, it will be difficult to induce patient to sleep, because it against the effect of like propofol or something like that, and it increases sensitivity to volatile anesthetic agent as well. But in Thailand, because we don't use the medical cannabis, we use something else like underground, so we don't exactly know the doses. So it's very challenging.
That is also very dangerous, and it's also dangerous because it's very tricky to have a pharmaceutical grade product from cannabis. In Italy, cannabis is also used to decontaminate grounds, okay? Because the cannabis will vacuum everything. So we have to keep that in mind when the street market is offering. There might be all kind of product inside, without saying infection as well, like mushroom, like contaminants, bacteria, which is obviously for cancer patient is a big issue because they are immune depressed. So we see at times, pneumonias from very strange sort of contaminants happening, and then we find out that the patient was using cannabis from the street. So that is something to really tell the patients, the sicker they are, the more important is to have a very, very controlled, in terms of quality, product.
I have a patient with spinal cord injury and severe neuropathic pain, and he had problem about major depression, which had many psychiatric drugs. We can use CBD for severe neuropathic pain.
So, my suggestion is always to start with the safest product. Okay, so it's obvious that CBD is a neuroprotective agent, has been shown to be effective on neuropathic pain in sort of preclinical studies, and in also some clinical, but very, very small, sample. So in our experience, we see some patients doing very well on CBD. And if you're doing very well, why don't you need to throw THC, which can bring a lot of complication, for the patient. So that is our first step in general. We use CBD during the day as much as possible, and Nabilon at night because it has more sedative characteristics. Okay, so it's more like a THC indica type, and we'll see that in our case presentations. Okay, so our recommendation is always to start with CBD. If a CBD by itself is not enough, then adding, THC will be suggested, of course. But if you don't have CBD, you have to start with a mixed, with a balanced product, THC, CBD. You don't have really alternative. I would say that for neuropathic pain, to start just with THC is not what we like to do in general. We want to always have a bit of CBD involved, whether it's CBD as a pure product or CBD in combination with THC.
But he has problem about major depression of many psychiatric drugs.
Depression?
In this case.
You mean depression from a CBD use?
No, he has from another problem. He had major
depression. Okay.
He had many psychiatric drugs that is on contraindication.
Okay, sorry. I thought that you were mentioning psychiatric drugs to treat his neuropathic pain. Okay,
no. He has psychiatric drug for treat major depression.
Yes. So we cannot expect cannabis to be a miracle. Okay, that does everything for everybody. You have to introduce cannabis for a specific objective, and at times has to be used concurrently with other medication.
We try. He has 5 times of operation, spine operation, and try many medicals. Medication.
So, but are you talking about the neuropathic pain, or you're talking about the depression?
Neuropathic pain.
Okay, so yes. So that is, again, first of all, we need to see, I always consult my, my books to see if there is a possible interaction, okay? And then I try to understand what is this interaction. Is the metabolism of cannabis enhanced or slowed down by, or is metabolism of other medication enhanced or slowed down by giving? And then I work my way to a safe trial of CBD, okay? And again, monitoring the patient, understanding if, there might be other issue that, for instance, CBD may also increase fatigue in patients. Unless you have a CBD that has a specific profile, which we'll learn a bit more today, which is called sativa, which is energizing, most of the CBD that are available are either hybrid or indica type. So they may increase fatigue, and if fatigue is already a problem with this patient because they are using other medication that makes them fatigue, or because they have cancer that make them fatigue, or multiple sclerosis, make them fatigue, then you have to be careful with the CBD because you can make the patient worse in that regard, and even more depressed. Okay?
And after we use, for cancer patients, after we use cannabis and the disease run down, the PPS drop, and they have some problem about renal failure and liver failure, how we adjust those for THC?
So first of all, it would be nice if you introduce yourself. Are you a physician or a nurse?
Physician.
You're a physician? Okay. So it's very important for me to understand also. So As I mentioned yesterday, cannabis is not something to use when the situation is not stable. So if a patient is dying, if a patient deteriorated, it's too difficult to understand how cannabis will work in these patients, whether it will make things better or worse. They may become delirious, they may have all kinds of complications. That is not the time for cannabis. Sometimes happens that the family comes to you and say, please give a cannabis because they think that would be a miracle, like they will heal the cancer, make them feel better, more. It's not really something to do. You have to use medication that you know very well how they work, the dose, the possible side effects. Cannabis is always a new venture in any patient, and you have to have time to understand what is the sweet spot where cannabis will work for this patient the best.
You stop cannabis or just decrease dose because they use cannabis for a long time and then PPS drop. How we stop?
So it's a judgment call. I tell you what is the reality and which is different from the theory, okay? The theory will say to reduce the medication and try to keep it on board. The reality tells you that the patient goes to emerge. And when it comes to emerge, the first thing that they will do, they will stop the cannabis, okay? Because they will think that all the problem relates to cannabis, okay? As they think about methadone, when people is not familiar with methadone, something happens, it's a methadone fault, okay? So, for my patient, when they deteriorate, the first thing I try to remove whatever is not simple, straightforward, replicable, and everybody knows how it works, okay? So that is my approach. That is the type of thing that
So the titration. So an overview of the titration. I will go a little bit. So some of the administration mode that we have in Canada, we have that yesterday. So for some of you that were not there, we have oral preparation as oil or capsule of oils. We have sprays, dry cannabis in inhalation or in joints that can use the patient, and topical product. So the frequency of the dose depends on the targeted symptoms. So when the symptom is present, how long does it last? So if they have only night problem, it's only at bedtime. HS means bedtime. If it's through the day, if it's ongoing, continuous, or it's more in the morning when they wake up, or only during the day that they have problems. So we will decide the administration regarding where the symptom is the worst and what is the best for the patient. So, and usually for liver dysfunction or renal dysfunction, we will use only once a day the dose at the maximum. So precaution in dosing and titration. So factors that influence the sensitivity or the response to cannabis, so naive patients, cannabis-related side effect in the past, so if they try cannabis in the past and have like or anxiety attack, panic attack after smoking cannabis. For elderly patients, if the patient is really already sensitive to all the medication, polypharmacy, hepatic or renal dysfunction, and any other precaution. So the maximum doses not the same for THC and CBD. So usually the THC we will go not more than 50 milligram. There's some clinical study with THC that they go up to 25 to 28 milligram of THC per day in patients with multiple sclerosis. And doses of 20 to 40 milligram per day have been used to stimulate appetite in HIV patients. And with the CBD we can go much higher. And even in healthy volunteers, there's a study that the dose go to 1,500 to 6,000 milligram of CBD without serious or severe side effect. So in the medical context, we use higher dose of CBD than THC. So titration, we start low, we go up slow, and we stay low. So why titrate? The endocannabinoid system develops a certain tolerance when constantly exposed to the ligand. And it's useful to reduce side effect of cannabis treatment to titrate. So we start with a very low dose that at the beginning might not be effective at all, no effect, homeopathic effect. And then we slowly increase the dose. The patient will himself slowly increase the dose until he finds the right dose for him. So the pharmaceutical cannabinoid that we have in Canada, Nabilon and Sativex, this I will pass it because I think it's not available here. So it was some example of titration. So for the dry cannabis, inhale dry cannabis, usually we tell the patient to start with one inhalation, then for the first administration, then to wait for 10-15 minutes to see the effect, and they can gradually increase the number of inhalation if necessary. So to a dose without a side effect. But if they go no more than 10 inhalation, even like 5 to 10 inhalation, no more than that, because otherwise it's not the cannabis is not the type of cannabis is not effective for them. So we can change strain or change type of cannabis to improve the effect. So the patient should not hold their breath during the inhalation. So after they find, like for example, to stimulate their appetite, 3 inhalation 30 minutes before meal. They can use it every 4 to 6 hours or 3 times before the meals. And we can optimize the baseline treatment to reduce the as needed. If the patient is taking regularly the as needed inhale or spray medication, we can start to increase the oil as the opioid. If it takes more breakthrough analgesia, we can increase the long-acting opioid. For the titration of cannabis oil and the capsules, so usually what we start with 5 milligram of CBD, but you will have more oil 1-to-1 or THC rich. So with a 1-to-1 oil, we always check the THC milligram to start. So we start around 1.25 milligram of THC to 2.5 milligram THC. And then we calculate by the milligram per milliliter. We transform to milliliters for patients. It's easier because they will titrate with a syringe. So usually CBD and balanced oil during the day and THC oil rich at night. So, and we can start with only CBD first, and then ask the patient to slowly start THC, to titrate THC when they have a dose of the CBD. So usually we start to titrate every 3 days. So for example, they start at night, 0.2 milliliters for 3 days, then twice a day, morning and night for 3 days, the same dose, then 3 times per day, and then they slowly increase by 0.1 ml every 3 days until they find the right dose for them. For elderly patients, we can titrate only every 5 to 7 days, or even sometimes we do 2 weeks. We monitor the side effect carefully, and we consider only administration once a day or twice a day for a patient or any condition. So for the patient that are already using cannabis, I think in Thailand you have this problem too, with more experience. So we usually do the same, but we increase a little bit faster, or we try to convert a little bit the dose that they are taking and starting with a higher dose. So I will go in the THC, but so this type of titration, if you want to use it only at bedtime, if the problem is only around bedtime, or twice a day, or 3 times per day, this is how we can titrate. So, and for THC rich, so we start at even lowest dose, and the same. So and so for the patient, we convert to milligram to milliliters. So we have oils with concentration of 20 to 25 milligram of THC per milliliter. So usually they will start the THC-rich oil at 0.1 or 0.005 milliliters. So what we give to the patient is that type of table, that to take. So either only at night, we give only the night table, or 3 times per day. And that's where they will titrate. So every 3 days, you see day 1, 2, 3, 4, day 1, 2, 3, sorry, and only at bedtime, or at the beginning, if you want 3 times per day, only at bedtimes, and twice a day, then 3 times per day, or only in the afternoon and morning, afternoon. And for 1-to-1 oil, and for THC-rich oil, that we start at the lowest dose. So when taking the first dose for the patient, we give general advice. So usually it's better to start at bedtime, because if they have side effect, they will go to sleep. So this is not so bad. Or otherwise to start over the weekend when they don't have any appointment scheduled or anything scheduled. And to make one change at a time. So if they have 2 different oils, just to start with only 1 oil, and then to add the other one when they are stable with 1 oil. So some mitigate side effects. So if the patient experience mild side effect, they can keep the same dose, and the side effect should disappear over time. So they not titrate, they stay on the same dose, and they wait until the side effect has disappeared before increasing the dose. And if the patient experience a moderate to severe side effect, they should reduce the dose. and wait longer before increasing the dose. So for example, they have a side effect when they increase to 0.4 ml. They go back to the previous dose that they were taking, so 0.3, and they use it 0.3 for 1 or 2 weeks until before starting to increase again the oil. So other strategy, if your patient have a side effects, we can change the administration method. We can try another cannabis variety or strain with different cannabis concentration, and we can discontinue the treatment if the strategy doesn't work. So the table that was presented yesterday too by Dr. Vigano. So if we have a cognitive effect, we slow down the titration, we reduce THC or increase CBD, and we restart the treatment after discontinuation period or anxiety. There's a few help in this table for you to know what to do in case of a side effect. So our clinical expertise on which cannabis to use to start. So THC will be used for the effects of the emotional dissociation, the personalization of the suffering. So for the PTSD syndrome too, pain, nausea, sleep, appetite, and so we cannot use it in an unstable cardiac condition. And there's a risk of addiction. THC and CBD, usually the combined oil, we use it in a frail elderly patient who has already a lot of medication. That will be the safest way to start and to be effective more rapidly, because only CBD can take a longer time. In chronic pain too, we use it. So after that, CBD, so it will not be available here in Thailand, but it's the one that usually we start with for naive elderly patient or young patients. So the cultivar that we talked a bit, so the indica and the sativa type are different in the leaves, but right now there's more hybrid plant. There's no more like indica or sativa plants, but there's some clinical indications. So the indica will be more for the nighttime and relaxation. The sativa will be more uplifting and euphoria. And hybrid are a mix of the both. So important to have in mind the tolerance and the dependence to the cannabis too. So the tolerance is characterized by an acceleration in the degradation of the cannabinoids, an increase in the cannabinoid receptor stimulation threshold, and in decrease in the number of these receptors. So during a prolonged consumption of cannabis, the nervous system adapts to the new conditions. So, and some study that said that in the medical purposes, the use of cannabis, and for therapeutic indication, the tolerance develop very little, even after several months of treatment. So the risk of dependence to cannabis is low even after prolonged exposure in a therapeutic context. Signs of withdrawal are reduced compared to alcohol, benzodiazepine, and opioids. So it's less symptomatic, and you cannot die from a withdrawal of cannabis. So the patient will report excessive sweating, irritability, sleep disorder that can last for a few days to 2 weeks at the maximum. So we always assess the risk of dependence at the first assessment. If it's moderate to high, we usually try to avoid as much as possible the THC or to limit the possibility of the patient to buy THC. So even for medical purposes, usually the risk of dependence is low. So thank you. And do you have questions? Comments? Yes.
For chronic pain patients, even though the slide you say it's a combined just for chronic pain patients, but always start with CBD only.
So, cannabis is not only a science, it's also an art. Okay? And the art comes from understanding the patient that you have in front of you.
Right.
Okay? So, for instance, I am particularly sensitive to patients that have been using cannabis before for recreational purposes. Okay? So, when, for instance, you are dealing with somebody that has been using cannabis before, you will be very, very cautious in using THC. And you will have to establish a very important therapeutic contract. And the way that you establish that is not just with one visit. And you will start using things that potentially you will not use in other patients as a first line, simply because you want to assess if this patient is able to stay into a therapeutic relationship. So when we are talking about choosing for whatever syndrome we are considering, those are part of the decision-making aspects, that factor. So there is never a generalizable approach. However, as for everything, you want to start with the safest approach. You have to remember one thing. When the patient has been using street cannabis, okay, the street cannabis is usually of poor quality. So they may use a lot, but in reality, there may not be very much THC inside. So it's not, you can never assume that the patient may have already a high tolerance to THC. You may have a different protocol which will be faster for the titration, but most of the cases always start low in any case, okay? Or a bit higher, but not much, not very much. And also, by starting at a lower dose, is already a way to assess is the patient able to follow myself. Because the patient comes back and say, doctor, I don't trust you, I want this, this and that, okay? So for me, that is already a sign that we are not on the same page. And I say, look, I would like to help you, but I don't feel comfortable, so you are now. In Canada now, we have also the legal recreational cannabis, okay? So what I tell my patients, say, look, it's much easier to go to the outlet where you can get the recreational than come to me, because I will limit your use. I'm here to be your physician, not your companion for using cannabis, okay? So if a patient understands that, it means that I can work with that patient. But if it doesn't, then becomes not just the fact that the patient, I feel uncomfortable, but there is also a legal aspect, okay? If this patient become intoxicated from cannabis, and I authorize this patient to buy certain cannabis, they will call me, not somebody else, to find out why that has happened. Okay, so there is also a responsibility. So I tell my patient, when you are with me, you're not allowed to use any other type of cannabis where I don't know the dose, I don't know the quality, and I can lose my license if something happens. So, generally speaking, that is the message.
Do you hospitalize the patient for the titration, or do it outpatient or over telephone?
Never. No, we don't have that possibility. But again, we have a very good system to monitor patients, and we always have a way. Obviously, there is always the mistake, the overdosing possibility, okay, which we cannot control, but in general is not a frequent happening. But that is why cannabis is not like another medication. You just write a prescription and take it, and we'll see you in a month. It's a very sort of elaborated process. We'll see where you need time. Okay, so I work, for instance, always with a nurse because that helped me a lot in terms of all the teaching and training. Otherwise, I would have to spend 2 hours with each of my patients, essentially, and I would not do a good job like we do. Okay, so that I try to limit my really intervention where it's more effective.
นิดนึงนะคะขอ clarify เรื่อง dosage นิดนึงไม่ใช้ได้ไม่ที่ทำกันจะใช้ได้
clarify dosage นิดนึง I'd like to clarify about the composition of the milligram of THC of our cannabis oil คือถ้าที่เขาจะเขียนเนี่ยของต่างประเทศเนี่ย cannabis oil ของเขาเนี่ย1 ml ของ THC นะคะจะเท่ากับ25 มิลลิกรัมแต่ของบ้านเราที่ใช้อยู่คือขององค์การเภสัชที่ทุกคนได้ไปเนี่ย1 cc มันจะมีแค่13 มิลลิกรัมของ THC เท่านั้นนะคะต้องเข้าใจตรงนี้ด้วยเพราะฉะนั้น1หยดของมันจะเท่ากับ 0.5 มิลลิกรัมขณะที่1หยดของที่นี่เขาของเขา25มันจะเท่ากับ1 มิลลิกรัมนะเพราะฉะนั้น starting dose ของเราแทนที่จะเป็นสมมติถ้าเขาบอกให้ใช้ 1.2 ใช่ไหมฮะเราอาจจะต้องใช้2หยดนะคือโดสของเรา